This Week in Virology, the podcast about viruses, the kind that make you sick.
From Microbe TV, this is TWiV, This Week in Virology, episode 816, recorded on October 13th, 2021. I'm Vincent Racaniello, and you're listening to the podcast all about viruses. My guest today, from the University of California, Berkeley, David Tuller. Welcome back.
Thanks, Vincent. Good to be here.
Last time you were here was August 2019.
That was, I think, a few centuries ago, wasn't it?
It seems
Before
like
we knew of anything called COVID.
Given current history, yeah. And that was called Call Me David Tuller. Remember, it's like the beginning of Moby Dick.
Oh, right. That was, that's what we were talking about, right. There would just been a couple of articles that had been in by Reuters and in The Guardian that had been critical of me, I guess, that year.
That's right.
And one of them referred to me as an activist who calls himself, or activist called David Tuller, as if that wasn't actually my name.
It's so crazy.
Yeah. Well, there's been a lot going on since then, but I think the most, one of the really interesting things for me is just that, the pandemic, in a way when it started, anybody who'd been involved in this world figured that, or knew anything about, post-viral states, figured that there would be, very early on, figured there would likely be a wave of people reporting prolonged symptoms of some kind, possibly similar to what we think of as ME or CFS. The categories are all a little confused. But so that there would be an ME/CFS type syndrome coming out of it for some people. And because of the numbers of people infected with coronavirus, we've certainly obviously seen that to be true in what's being called, quote, long COVID, which can have multiple definitions depending upon who's speaking. But as many thought, that this has really turned out to mean that a lot of people for the first time are hearing about ME. And if they're calling it CFS, or learning this new term, and that there's some connection possibly, and so on and so forth, and that it somehow relates to long COVID. So, there's some people who are, very concerned about this because they don't want ME and long, ME is very specific, more specific in some ways, and they don't want long COVID all kind of being wrapped up in that. But, I think in general, the science is trying to find the parallels in the U.S. especially, and elsewhere. But the NIH has done some funding on this and drawn attention to the possible similarities. So that's just been very interesting from someone who's been looking at this for a long time to see suddenly more attention thrown on this. On the other hand, we see a strong movement to approach people experiencing these prolonged symptoms, which in many cases resemble the prolonged symptoms that people with ME/CFS or ME report, are the same people who always considered those to be psychogenic or psychosomatic and were proposing psychobehavioral treatments, are doing the exact same thing with long COVID, or with parts of long COVID, or with the kind of category, and are presuming that people who are suffering prolonged symptoms in the absence of definitive, biological evidence of ongoing pathophysiology, which we don't have really at this point in a solid way, are somehow responding to anxiety, depression, post-traumatic stress disorder, and so on and so forth. So you see a lot of the same people, and referring to the PACE trial as evidence that the best approach for these new people is cognitive behavior therapy and graded exercise therapy. So, and that's currently being, fought out in both the U.S. and to a very significant degree as well in the U.K. and other European countries.
So I should say that you actually we did a TWiV on long COVID way back in November with Mady Hornig and Fiona Lowenstein. And of course it was remote.
Right. So that was, I think, in June or May last year.
November 2020.
Oh, but there was something else. No, there was something in Health Affairs that we had in June.
But I'm talking about a TWiV, though. We did that with you, right?
Yeah, and Ed Young wrote his first piece on the long haulers in May, I think, of 2020.
Yeah, and he was supposed to actually come on that episode, but he bailed at the last minute. Yeah.
So, I mean, and again, I don't know that he had necessarily thought about, ME or chronic fatigue syndrome all that much, but he was really someone who talks to patients and talks to people and listens. And so was reporting things. And, again, it seemed to come as a big shock to many people that there would be these many people reporting symptoms. But of course, if you've looked at the research going back on previous, epidemics and just in general after infectious viral infections and some other, bacterial infections and so on, but if we're talking about post-viral syndromes, it's really not unexpected at all. It's just surprising to people because it's happening on such a worldwide mass scale with similar reports coming from every country. And again, similar attempts by a number of people to sort of suggest that it's largely a psychosomatic phenomenon. The Wall Street Journal had a very, very strident opinion piece, I think, in March from a psychiatrist who basically dismissed it all as just mental illness and, figment in people's imaginations largely. And just recently there were an article in the American Spectator, not that I read the American Spectator, a very conservative publication with any regularity, but they wrote about the myth of long COVID. And then a publication called Spiked in the UK, which is a kind of libertarian quality, very odd, provocative for its own sake and kind of, right-wing libertarian kind of publication. They wrote about, is it a myth? They use the word myth also. They just put it in a question mark, but of course they think it's largely a myth. Again, in terms of the fact that the organic basis for these prolonged symptoms are as yet unidentified or as yet pinned down. But it's clear that, people are not having tachycardia, the dizziness that people get because their blood pressure is going all over the place when they stand up, POTS, these dysautonomia, these kinds of blood pressure variations. That's not because they're having just anxiety or some depression, and the people who are suggesting this are also saying that media coverage and just people writing about long COVID will encourage more people to report long COVID, which to a certain degree is true, but it doesn't mean that everybody who's coming forward with sort of reports is somehow psychogenically inducing symptoms. I imagine some people do that, but that's clearly not the case for a great many of these people. And many of them are clinicians. Many of them are clinicians who, who I've talked to, who might formerly have had the same attitudes towards, say, patients with chronic fatigue syndrome now are finding themselves kind of burdened by the same bias against what they're experiencing.
So let's talk a little bit about what's happening with ME/CFS. Now, for new listeners, you've been writing about this for many years, right? Right.
Since I wrote my big investigation on Virology blog, this is October. It was 6 years ago this month. I wrote, and I thought that was a one-off. I thought that okay, I wrote this big thing. This study is incredibly bad. This is the PACE study, published in 2011 in The Lancet, and then subsequent publications in other journals that purported to prove that graded exercise therapy, which is a steady increase in your exercise, or cognitive behavior therapy to alleviate you of the false notion that you can engage in graded in gradually increasing exercise. Were the ways to go and were actually curative treatments based on the theory that the illness was perpetuated solely because people were deconditioned, and they were deconditioned because they had inconvenient or dysfunctional beliefs that they suffered from an organic illness that prevented them from doing things, or made them get worse if they did things. So now we've subsequently learned through reports and whatever, that the main symptom, according to National Academy of Medicine, the former Institute of Medicine, is really a systemic inability to physiologically to tolerate exercise, that something going on metabolically, immune related, or in some way to cause an exacerbation of all symptoms if you exceed your available energy limits. And so graded exercise therapy in particular is now seen to be contraindicated as a recommendation. So what's happened in the last few years, and this is all coming to a head now, this month, next week, in fact, is that in the UK, there's an agency called the National Institute for Health and Care Excellence. It's not a nonsensical name. National Institute for Health and Care Excellence, NICE. So NICE is charged with developing clinical guidelines for various conditions. And in 2007, they did one for what was they then called CFS/ME. And that was the earlier days. The idea was that at that point, graded exercise therapy and cognitive behavior therapy had been somehow shown to be effective, even though looking back, the studies are all pretty bad. And there was sort of a group in the UK, I have called them a cabal, but let's just say a group of colleagues, all sort of interconnected and mutually interested in promoting their perspectives and supporting and peer reviewing each other's research, this was again, a psychosomatic phenomenon and induced by these deconditioning and dysfunctional beliefs of having an illness. And that became the standard of care, essentially. And then in 2011, the PACE trial sort of reinforced that notion. And pretty much all around the world, including in the US, those were adopted, those treatments. And but in 4 years ago, it was sort of the time, 10-year period, to sort of review whether they needed to update these guidelines. And at first, NICE said no. And then after there was a fair amount of pushback, including from some powerful people and members of parliament and so on, that they needed to, I'm not sure, actually, I think members of parliament might have been involved at that point. Yeah, some members of parliament, that there needed to be a review. And so they finally capitulated to doing a review. So they spent a year putting together an extremely balanced committee with some patients, but also some scientists who were, and some clinicians who believed that the recommendations were wrong, the previous recommendations, and others who were very much in favor of them. And it was a kind of excruciatingly balanced committee. The committee spent 3 years reviewing the evidence and doing, they released a draft last November. Everything was a bit delayed because of COVID. They released a draft in November, and they were supposed to release the final guidelines in August. When they released the guidelines in November, they also released a review of all the evidence that was extensive. And according to the evidence review, as they did it, using what's called the GRADE methodology, which is a systematic way to look to sort of assess evidence, they decided that all the evidence in favor of these interventions was either of very low quality or low quality. That was it. This, of course, got a lot of, outraged pushback from clinicians who believed, they were doing the right thing and said, well, we know this works from our clinical experience, and that's not the right way to look at the evidence base, and you judged it all wrong. Anyway, the final version, which was, so basically everybody had a moment to get, a period of weeks to provide response to the draft. And then NICE the committee produced a final version. That was supposed to be released August 18th. The day before, NICE announced, we're halting publication because, and it turned out we've had some objections from some of the royal colleges. And the royal colleges are really the trade associations of doctors. They sound very hoity-toity by being royal colleges because they're chartered by the crown going back, however many hundreds of years, some of them. But basically, they're just a trade association representing doctors' interests. So let's just think of them as professional trade associations in our conversation and not the royal colleges. So a couple of them especially really objected because, again, the people who were supporting this now debunked kind of ideology of cognitive behavior therapy and graded exercise therapy are very powerful people. And from my perspective, and I've said this before, when it comes to this paradigm or this treatment approach for this illness, ME/CFS or ME, the UK has been operating in a kind of emperor has no clothes situation where the entire medical establishment that's defended this practice could take a time to look at the studies and see that they're totally ridiculous, and they're really not reliable or robust to base clinical guidelines on. But anyway, it is sort of the example. It would be sort of like the National Academy of Sciences, spending 4 years on a product and then the day before announcing that, half a dozen or whoever, I don't know how many, but some powerful people objected, so they're not going forward with it at that point. You would not really, it would be hard to imagine that. Not that I'm not trying to sort of, in this particular process, I think the UK seemingly has a problem here because I don't think that's really the way things can function, just because a couple of powerful bodies, when you've spent all this time going through a process and following your own process, and NICE has been very good generally in this particular thing about following its process. And it has. And when it announced the delay, and I said, defended the product, then they decided they were going to have a roundtable. And on Monday, there's going to be a roundtable meeting with the NICE people there, representatives from some of the patient groups or the advocacy groups, and representatives from, I guess, the trade associations of medical interests, of powerful medical interests that are objecting. And, it's a really kind of interesting situation. The hope is that NICE is using this just to give these dissenters a chance to air their views and have their hissy fit. And then is going to say, well, we went through this process. This is what it is. We're publishing the guidelines as we came up with them. It's hard to see how NICE can retain any credibility if it's going to bow to what really seems to be kind of basically these trade associations have publicly made it clear that they don't intend to accept the guidelines, and they don't want to follow them. They're not going to implement them, and so on and so forth. So it's sort of allowing the clinicians who claim to have a lock on the truth, even though this committee doing the assessing has assessed the evidence as very low. So it's an interesting fight, and it will be very interesting to see how NICE plays it, because no agency wants to be in this position. Every agency wants to defend its product and stand behind it. And so we're going to have to see, is NICE willing to defend its product in the end and stand behind it? Or is it going to blow all its credibility by watering down these recommendations? I should make clear, the new recommendations make it very clear that there's no treatments that are curative, that graded exercise therapy, in other words, fixed incremental, every 2 weeks you increase your amount by this much, that's not recommended, and that cognitive behavior therapy, that on the basis that people are deconditioned or that they have abnormal beliefs or some sort of problematic beliefs about their illness, and that's the reason why they're sick, is also not recommended. The guidelines do allow for physical movement and for physical therapists or so on to work with people. It's not saying you can't have supportive treatments, but it's saying that don't present these things as curative. And that's really what the fight's over, as to whether these things will be continued to be presented as curative or whether and again, cognitive behavior therapy. Now, there's often room for psychological support. When people have a chronic illness, there's all sorts of things that you might want psychological support for. That's very different from saying, if you do this, you will get better from the illness, as opposed to you will be adapting better to your illness. Those who are opposing this say that if you teach people to adapt to their illness, they'll adapt to their illness. And there's been a lot of talk in the past about their fulfilling their sick role, and they want recognition from society, and that's why they continue to have these symptoms and stay sick. And that there's all these groups saying ME is an illness, and therefore if you join these groups, then you'll be supported in your abnormal beliefs that you have an illness and so on. So, and this is now a proxy, really, in my mind, for long COVID, because the same people want to be able to apply the same paradigm to long COVID, even though it hasn't worked for ME.
So are you saying there's going to be a PACE trial for long COVID?
Well, there already are. I mean, they're testing cognitive behavior therapy, in the Netherlands. They're testing various kinds of exercise rehabilitation. The same people are saying, from the beginning, the PACE authors were saying these people need exercise. Once we find out that the people after they've had the acute bout of COVID, if we can't find anything wrong with them going forward, then they need to, get the exercise, or they need psychological help to get them out of their mindset. And so they've cited the PACE trial as evidence, and they sort of just, it's very Trumpian. I've always thought it's very Trumpian. It's just, the election was stolen. Well, no, it wasn't. Here, the election was stolen. It's like, you hear, no, your evidence is bad. Cognitive behavior therapy works. No, your stuff is really bad. No, graded exercise therapy works. It's like their mindset is so, they can't allow for the fact that what they've been promoting all these years is wrong.
So you've been talking about NICE in the UK. What's happening in other countries?
In other countries, so a lot of countries related to ME/CFS are waiting for NICE. So NICE is very influential. And so a number of countries have been are looking to see what NICE is going to do. And so they're kind of looking at this in a way, I think the way that some people looked at, the presidential election. You're like, how could this here's the evidence review came in, and the same people were on the committee. 3 of the people quit the committee. 3 of those who are very strong in support of cognitive behavior therapy and graded exercise therapy quit the committee at some point in the within the month before the final report was done, presumably because they didn't like the final findings. And so that's been used as saying, and the committee has been accused of being like overstacked with patients, even though there were, 4 or 5 patient representatives on it, not out of the 21-member committee. So, but other countries have been looking at waiting for NICE, and in some cases, I think waiting for their own recommendations. And in the U.S., I think people are still, there's much more recognition of it, I think, in general, but individuals still have a lot of problems when they go to individual clinicians who haven't heard about it or don't know about it. So I think in general, there's more kind of higher level sort of acceptance, or at least lip service to the fact that, yes, this is a physiological illness that people are having, and we really have to research it. Not as much money is going to it as should be, and so on. But there's, at least sort of a recognition that that's the case. In the UK, they really don't want to, a lot of it's that the NHS needs to save money constantly. And so on the one hand, it's great to have a National Health Service. On the other hand, when the National Health Service doesn't really want to appropriately deal with your very complicated illness, it's a real problem. And so it's much easier. Part of what's so some of the Scandinavian countries, Denmark is very heavily influenced by this paradigm, the kind of psycho-behavioral paradigm, and there are some powerful people there. Same with the Netherlands, Germany. So these fights are going in Norway. There's been big fights over this because there've been discussions of what kind of trials to do. And there's, in every country, it seems, there's kind of a battle between these kind of 2 opposing paradigms, really, of what these post-infectious illnesses are, and what ME/CFS is, and what long COVID is, and whether they're amenable to treatment by psycho and behavioral things. It's really complicated by the fact that these are all not one thing, and they're all probably clusters of things with multiple things going wrong. So it is very complicated, but you do see the same battle playing out. And the argument, again, is based on the people in the UK, they just misstate the state of the evidence. Whenever they publish studies, they ignore the fact that their research has been shredded to pieces. They don't like that, so they don't mention it, and they kind of, other people from the outside see it, but within they're struggling with it. And I see the same thing happening with long COVID. And people reporting a lot, going to clinicians who, in both countries or all around, who really don't believe them, or, again, say it's anxiety. And sometimes these are clinicians who, or pulmonologists who know what's going on, and they're told, oh, you have anxiety, or you're just depressed, or, whatever it is. So I think it's a real... Yeah, I don't know. I'm not sure. There's a larger issue here about, about medically unexplained symptoms. I think we've talked about that before, and it all sort of plays into that larger confusion about what to do about symptoms that people are experiencing that have no immediately identifiable pathophysiology, but that, and that one group then might dismiss or might treat as a psychiatric disease in the, based really on the absence of evidence, not on, for the most part, positive evidence of that.
Well, I think from my view, part of the problem is that the journals are not retracting. So the big one, the PACE and the Lancet, the editor will not retract that one. Then there have been some other smaller ones that you've written about. And there seems to be this entrenchment. Now, that's different from the Wakefield story where the journal did retract, even though Wakefield didn't retract his bogus measles data. The journal did, and that really helped. So what is going on with the journals here?
So, this is specifically not just the Lancet under Richard Horton published the Wakefield study and then, defended it and then had to retract it. When PACE was published, he came out, the same Richard Horton, came out swinging and sliming patients as being destructive to the scientific project and defending the study. And he clearly, in his statements, didn't really understand what the study was about or what they were doing. They fast-tracked it to publication for reasons that nobody has ever explained. You don't fast-track something to publication usually unless, now you do because it's, coronavirus or whatever, but this was not a study that was going to change practice. There was no reason to rush it through very complicated trial peer review, which they did. Once he came out defending it, his journal published a study in which people could get worse on the main outcome measures and be counted as having passed the outcome thresholds. That's a fact. He published a study in which outcome thresholds and the entry criteria overlapped. That's ridiculous. And he knows that, and he won't correct it. And you yourself had the experience of sending him that letter that he said they would publish essentially a letter, and then we were just ignored. We were vetoed. It was vetoed by the PACE authors. Who shouldn't
be given any say in the matter.
Well, yeah, they should be given a response, but they shouldn't be given to them and say, do you see anything new here? When 42 experts from Harvard and Columbia and Berkeley sign a letter and, and also wherever else, and then the PACE authors say nothing new here, it's ridiculous. So it's really and again, I just think, I don't know what Richard Horton's thinking or why, he's never responded to any of my, concerns. And, or then we sent them a letter with 100 plus, people from around the world, and he just ignored it. So I don't understand it, but it's a major problem in the scientific world, not just limited to this.
For sure.
Issue,
absolutely. Absolutely. So for the past 6 years, since that first article that you thought would just be a one and done, you've continued to write multiple times a week now at Virology blog. And I noticed not too long ago you wrote an article while Nice Waffles U.S. specialists published new clinical guidelines for ME/CFS. So what's that about?
So basically, there's a group of clinicians, probably, I guess I don't know how many were in them, 15 or 20, I'm not sure how many total in it, who, have been meeting the last few years. Mary Dimmock, a patient advocate, her son has been ill. She was very involved in organizing that and sort of pulling it together. And so they put together, and they published in the Mayo Clinic Proceedings, or the Proceedings of the Mayo Clinic. It's not the Mayo Clinic, but it's the journal sort of affiliated with the Mayo Clinic in some way. Their own clinical guidelines, essentially, for how to treat patients with this illness. And, so I wrote, one of the things I did in response to the NICE guidance was that I put together a letter, an open letter to the head of NICE and sent it to her, saying all, basically objecting from, experts, academics, scientists, and people who know about it. So that was signed by many people. I just sent it twice, and the second version was signed by, 120 or 130 experts, and then maybe 100 and something 120 or 30 organizations from around the world. But when I sent it to her, I said, I just want to point out, in contrast to what's going on in contrast, or I just alerted her to the recent publication of these new Mayo Clinic proceedings of the Mayo Clinic guidelines as a reference to note that other people, other experts, were disagreeing with the objectors to the NICE guidance, and to sort of, and I got a couple of short but very gracious responses from her. Not that that means anything, but they again put together a round table, which is happening on Monday, and so at that, everybody will presumably get their say. And NICE will listen, as they say they just want to listen. No decisions will be made there. And then after that, at some unspecified point in the future, NICE will decide, I guess, what they're going to do. If they're going to publish this as is, which hopefully is what they'll do, in which case I think they will kind of heighten or reinforce a reputation for some independence from pressure, or they're going to fold and do something, not publish it at all, perhaps, if that could be an option. They could. One option is they could not publish the new one, and they could unpublish or retract the old one, so there is no guidance at all. Or they could publish this with some changes, in which case I think their credibility is sort of destroyed. So they have some choices to make. And I think it will be interesting to see whether the pressure campaign against them, by these powerful medical interests who've all been in a state of, I think somewhat delusion about the quality of their research, how much power they actually have. I think I think a lot of them are sincere. They see, and I think they do whatever, and the patients that like what they're doing, I guess, come and say, "Oh, it's great," and they claim that they make claims that really aren't supported by the evidence about the numbers of people who improve, or and a couple of things that's happened. There's been a flurry of publications in the last year, or it seems like a flurry of publications seemingly published to support their claims. And, a colleague, Brian Hughes, who's a psychology professor in Ireland, he and I published a kind of a rebuttal of one of the papers that claimed that, in clinical practice, they were looking at the clinic data that CBT proved to be successful, but it was all a complete mishmash of data manipulation and doing things badly. And so the journal refused to publish it, so we published it in a separate journal that allowed us to publish a critique. So they constantly have minimal data and make excessive claims based on those. And I just think it's really bizarre.
So there was, a few years ago, the CDC had made noise about making changes in what they recommended. Right? What became of that? Well,
so basically, the CDC... and I can't, the years blend in. I think it was 2017 now that the CDC finally removed their recommendations for cognitive behavior therapy. Basically removed the PACE paradigm. As much, they didn't, not completely, but they basically removed the recommendations for graded exercise therapy, for the things that people had abnormal beliefs, for cognitive behavior therapy, and so on. And so, but they did it very quietly, and they refused. I just kept pressuring them to make, why won't you say PACE is a bad study? You actually owe. I was kind of ashamed as a public health professional, because you're supposed to, acknowledge when you make mistakes and then maybe even apologize for it. And they've been supporting. If you look at PACE, anybody who looks at PACE, as patients did when it was published, could have told immediately that it was nonsense, that there were so many flaws with it, so many problems, and that they did things that you can't do. And this was pointed out over and over by patients very politely in all sorts of venues. And CDC had access to smart people who could have done the same thing, and they refused to do it, or they refused to acknowledge it, and so they still have refused to ever say that PACE was a problematic study and that they were wrong to rely on it. And they owe the public that, but they refused to do it. So they kind of removed it. I noticed someone had mentioned it on a blog site or I think on a forum or something, so I wrote... So I wrote to them and I said, "Are you going to announce this, or are you just going to quietly make this change without telling anybody?" And then they sent me some wishy-washy statement about what they had done. But then they did remove them. And so, they had other products that still sort of reinforced them, and they've had to be pressured a lot still, or not. I shouldn't use the word pressured, but they've had to, there's been a lot of advocacy pointing out scientific issues with their work that has gone on over the years. So that became something that in the UK also, when NICE was then considering whether they had to reevaluate, one of the arguments was, well, if you say you don't, you're directly contradicting what the CDC has done. And so even though in the UK they want to say, wait, we do our own science, we don't have to, of course they don't have to rely on the CDC, but you also don't want to be a scientific agency completely out of step with other major public health agencies.
So, as you know, long COVID has just received a big cash infusion from NIH.
Right.
Now, in contrast, Jenny Spotila annually reviews CFS funding. So,
right.
How do they compare?
Well, they got 1.15 billion, I think, for long COVID.
Yeah.
CFS or CFS was in the 5 million range for many, many years. And even if you looked at that, as Jenny often did, some of that was just fatigue-related research that they classified as for CFS, or it was sort of other things that sort of were only vaguely related that they managed to sort of slough off as CFS, or it wasn't really even the amounts. And she sort of found the same thing. Now it's up to, 12 to 15 million a year. I mean, they funded some centers and there's work going on. So it's better than it was. But, with long COVID, there's a concern that they might lose focus on CFS, and some of the long COVID money is also being used to sort of look at interrelationships with CFS. I'm not a scientist in that way, so it's hard for me to really assess whether what the science that's being done is good. But I tend to believe that people, what's happening with a lot of long COVID people, they're having, the infections are triggering dysautonomia. So they're having a lot of problems with orthostatic intolerance and with POTS and dizziness and things. There are things you can do to treat that. That's the same thing with CFS. People, that's one of the a common symptom people have. People are getting this, if you look at the surveys, there's a lot of post-exertional malaise, PEM, which is the term for these relapses that people have in ME. People are reporting that also with long COVID. So some people with long COVID seem to have specific identifiable, lung damage or other organ damage, and they're kind of in a separate category because everybody agrees that they have something organic. It's the people who have the non-specific chronic symptoms that seem to persist, even in the absence of currently identified organic damage or systemic damage that are kind of the ones that are presumed by some to be psychogenic or psychosomatic and presumed by others to be things that we can't identify yet. And that's the profound fatigue, the relapses, the dizziness, or the stuff related to orthostatic intolerance, some of the other things like that. Headaches, a lot of reports of migraines and headaches that people are getting.
So do you think the emergence of long COVID and the focus on it, because as you said, there's so many coronavirus infections, do you think that will help CFS in any way by understanding or by therapy or?
I tend to think so. I think we'll find out. But I tend to think so because I tend to think that, some people have there are different definitions of ME, and some of them are a little more narrow or relate to, or very more specific in the kinds of tests that can be done. Some of them are broader, the ones who have, so I don't want to go into all the details at this point. So I think there's a range of concerns about that. Who feel that long COVID is really different from what they see as their ME, but then there are others who believe that if you look at the processes behind post-exertional malaise, say, or the post-exertional symptom exacerbation, it has also been called, that you'll find similarities between how that happens. And that if you look at, again, the dysautonomia, that you'll find similarities in why that's happening after an infectious agent or after a viral infection. there's some people who think that, there's some persistence of, we call it post-COVID, post-COVID. But some people think there could be some persistence of viral particles or parts of the, remnants of the virus in different tissue. And there are people who think that about ME as well, that it's likely an enterovirus and that there could be ongoing enteroviral infection in some unidentified as yet organ. I have no basis for opining on these kinds of things. Some of those things may be possible. I tend to think that, if you look at these processes and and I think it's also just made, I think for some people that have spoken to me, say, well, they feel vindicated in the sense that people can see this is happening now. Some people might believe that this is mass hysteria, as it's been called on a worldwide basis. I tend to think that's a little less likely than a small or a certain minority of people who get COVID or actually remain quite sick from something that we don't quite understand. And to the extent that that sheds light on the fact that there is a range of post-infectious conditions that we don't understand and that people tend to get categorized as being hysterical or, psychosomatic patients and so on, I think long COVID in that sense not be beneficial, but will be at least beneficial in the sense that it will shed light on that and make people feel, hopefully, that their illness has more credibility and that people are taking it seriously.
Yeah, I agree. I think that's the outcome that is good, that we see one virus infecting people and then they have long symptoms. Whereas with ME/CFS, we've always thought there might be viral insults, but no one can pinpoint any particular one.
Well, the problem with ME/CFS has been that people get diagnosed with it only 6 months after is that within most of the diagnostic criteria, but really most people get diagnosed years later. And the reports of viral infection, that it comes from a viral infection, are generally self-reports that, I had an infection, I had some flu or I had mono or glandular fever, and then I never got better. So now we have in real time people getting an infection and then reporting it, so we're actually seeing it. Well, it's ME/CFS, it's always generally retrospective. And so there's a couple of studies now that are tracking, so we'll have much more better longitudinal data from long COVID, from all the long COVID studies of people from infection. And there are some cohorts where they were looking at people before infection. So now they can track those cohorts and see who gets COVID, who gets long COVID, and then who in 6 months might meet an ME/CFS diagnosis. And, this is all going to take some years. It's not like people are, but they're finding lots of interesting things in some of the long COVID patients that I think will hopefully yield maybe some ideas for treatments for ME/CFS as well. But that's the hope. Again, I'm not a scientist, so sometimes people say to me, this, that, and I'm like, I don't know.
Do you think that long COVID has somehow validated ME/CFS for some people who thought it was just psychosomatic, for example?
I've certainly talked to clinicians who have long COVID who felt that way, who before that were like, I don't know, and now they're kind of seeing, oh my God, I don't have these signs, but yet I can't go back to work because I'm just, I work for 2 hours and I'm exhausted. I can't work for the next 3 weeks. And so people who never, so I've seen clinicians who report that, and I think, other people as well who probably were, or probably didn't think about it for the most part, but who might have been dismissive. I think, we're all humbled when we experience something that we thought other people experienced and we don't experience it ourselves, and then suddenly you're hit with it. And I think most people, if they're reflective, are a little bit humbled by illness. So I think definitely that's how, when I've talked to, there's a whole, in the UK, there's a long COVID doctors group. And so I've talked to a number of them about their past, what did they think about ME before, and how has this changed their perception? And definitely I think it has. So, whether that experience then filters up, or whether, the notion that it's all psychogenic gets sort of becomes dominant. I think, if they find things as the science goes forward, that will help validate that argument. The challenge is that people have so many different symptoms, and it's very hard to track, everything. Some probably are related to long COVID, and others, are likely not, and who knows? So it's very hard to figure out, but I think that's science. I'm confused by why people find a really fascinating medical phenomenon. There's a couple, you could look at it and say, wow, let's really figure this out and find out what's going on. Or you could say, we can't find anything. These people must be having some, depression, anxiety, and PTSD, and let's just treat it like that. I am more inclined towards like, hey, this is fascinating. Let's figure it out. Like I would think if you're a scientist, you'd want to go in that direction rather than positing that just because you can't find something, it must be made up.
No, I think
it must be.
I think there are some scientists who are. I think Ian Lipkin is making some inroads, but it takes a long time, and it's not something that just smacks you on the head. You have to search really hard. I think the differences are going to be subtle, but they're there, I'm sure. And I agree. I think you shouldn't write it off as not having some molecular basis. I'm sure it does, and I'm sure it does for long COVID as well.
The same argument's happening now over so-called Havana syndrome, where you have more and more reports of these diplomats and people having these kind of brain injuries, and you have the same people saying long COVID is psychogenic, who are saying, oh, this is, mass hysteria, and who knows? I don't know, but the same cohort seems to want to make that argument all the time if they can't figure out exactly what's going on, or if it's an unknown phenomenon.
Yeah. What do you think of the name PASC, post-acute sequelae of coronavirus infection? I think it sounds fine to me. I think there's some concerns about it because of the word post, because people are thinking, well, maybe it's not post-acute phase. Maybe this is part of the, maybe if there's some continuing viral infection or continuing viral, remnants of viral particles, I don't know how that would work exactly. Yeah,
then
I've
seen some people objecting to the use of the term post.
Is that used outside the U.S., PASC, or is it?
PASC, I've seen it used. I think I've seen it used in some of the UK articles. I don't think they're using it. Basically, long COVID has become the term, and I think it depends upon, just making sure that when we say long COVID, we're clear. We're not talking, the thing that's better about post-acute sequelae is that it's clear it's sequelae. It's not, it's multiple sequelae of a large variety. Long COVID tends to make it sound like one thing, and I think that's some of the confusion in talking about it. Is that you can't say people with long COVID, all have ME or don't all have ME. People with long COVID have 500 different things going on. And some of them seem to meet the criteria for ME. Some of the various criteria for ME, there are multiple ones. So, it's not a one-to-one correspondence, and people with long COVID, again, have multiple different things, and depending upon where the virus targeted in their bodies, are going to have different things going on. So I think it's a big mess that probably is fascinating and I think obviously it takes years, and the problem is people want answers right now. And doctors are confronted with a lot of patients who they don't really know what to do with. And, basically most people who get a viral infection get better. And, many of the people who even probably are experiencing long COVID after 3 months or 6, whatever, will hopefully get better. I think we don't really know whether some of these rehab programs are saying, well, they took our rehab and they got better, and that proves that our rehab works, but you can't really do a study like that because you have to show that the other ones didn't get better, people get better. They tend to get better after viral infection.
Part of the issue is that it's not a long time yet after COVID began, right? And so in 5 years, will there be such a thing? Will, vaccinated people ever develop it? I think that's really interesting because, you can get long COVID after a mild COVID.
Right.
So if you get a mild COVID after vaccination, are you going to get it or not? We still don't know the answers to that. I think.
A mild COVID after the vaccination, but not from the vaccination.
After, you can get infected. So a small number of people get infected. They get a common cold, very mild. And maybe, so do they get long COVID or not? I think that'll be.
I think there's generally, they've said, we're not seeing long COVID after breakthrough infections, but it's too early.
It's
really
too early.
To say
I agree.
that.
There's no good papers yet. And the other issue is, Well, what was the other one that is relevant to this that I've just forgotten? Anyway.
Well, there was one issue one of the difficult issues with long COVID was that, of course, many people who developed long COVID didn't have viral tests because they got sick in March and April and May, and they were told by their doctors, don't come in, we don't have nothing, you presumptively have COVID, it sounds like, but even if you do, we can't do, and now, then 6 months later, they start having these symptoms, and then the systems don't recognize them as having had COVID because they don't have a PCR test because they couldn't get one. Maybe they don't have antibodies because it was too early or too late, or a positive antibody test. And now it turns out some people don't have a positive antibody test. So some of the anti-long or the long COVID is a myth, or the other mass hysteria ones point out, say, well, many of these people who say they have long COVID didn't have a positive viral test, without actually acknowledging that that's a factor. That's not their fault. That yes, maybe some of those people have anxiety and depression. Maybe some of those people are having anxiety and depression, and that is why they're not sleeping or whatever. But many of those people have had COVID, and they're having actual symptoms from their infection, and they're sort of being blamed for not having had tests, and that's not really a factor now because now everybody's getting tested. So if someone is sick now and then they have long COVID, they were in fact positive. So it's been very, very messy, and people with strong opinions have, made many stupid statements, I think.
No, of course. Throughout this pandemic has magnified that, but it's always been the case.
Right.
Part of the issue is, and this relates to something you've written about very recently, is that it was pointed out that, people who have influenza also have long COVID, but and it was criticized because that's not the issue right now.
That was so that was very interesting. So there was a study that came out in the UK that was looking at basically long COVID and percentages who reported what kinds of symptoms after, and then as a secondary matter, it compared it to the flu, and said, people with long COVID seem to really have more symptoms, and so we think it's a real thing. And essentially, I'm just paraphrasing, we think, and so they genuinely seem to be reporting more symptoms than people with flu, but people with flu also have it. So, okay, interesting enough. But the point was that there were a lot of people reporting long COVID symptoms. The BBC turned it into a sort of article about, people get long flu also, as if that was the point, and that wasn't the point. And so they made it the article, and then the two quotes from the researchers were about long flu, and okay, that's interesting, but it wasn't the point of the study. And I don't really know I don't know what the authors may have said other things to the journalist. The journalist chose to include those quotes, but it was like, this wasn't a long flu study. This was a long COVID study. Those were the interesting findings. That there were also people with long flu is also interesting, but it sort of diminished, it seemed to diminish the significance of the fact that people had long COVID by saying, yes, people have long flu.
Exactly. Well, in fact, as you said before, most people recover from viral infections, but there are also long-term consequences of many viral infections. They may not be continuous. For example, post-polio, right? You get paralyzed, you recover limb function, you're fine for 40 years, and suddenly you're paralyzed again. I wouldn't call that long polio, right? Because it's not a continuous...
Right, that's post-polio syndrome,
it's
isn't it?
So it's a long-term consequence. Mumps in some boys would make them sterile. That's a long-term consequence.
Or shingles. Chickenpox, shingles.
West Nile can give you paralysis and cognitive issues because it's neurotropic. So it's nothing new that there are long-term. But I think this is unique because it seems to be a continuation of the first acute infection, and many of the symptoms don't go away.
Right, and it does. Some of the clinicians are who are experts in ME are diagnosing these patients with ME. It doesn't mean maybe they have other long COVID things going on too.
Sure.
But they're getting an ME diagnosis afterwards. And sometimes that's actually, there's a lot of debate over the coding and insurance and how to get disability insurance and, all this kind of stuff that has to be kind of, the system isn't used to dealing with a completely new illness, then with a completely secondary illness after that first illness. So it's all very confusing.
Yeah, and there's a new coding just came out for long COVID. So what do you think of this observation, which Daniel Griffin has acknowledged that about 30% of long COVID patients who get vaccinated report some of their symptoms abate.
I've heard that, and that's, I think that's really interesting. There's also been a lot of, some patients with ME actually have reported that after they get the vaccine, they get much worse. So there are some patients who are having very negative. And again, is it hard to say whether that's a consequence of the vaccine, but to them, they're experiencing chronological associations between getting the vaccine and getting much worse. And I've heard also that some people with long COVID get the vaccine and improve. I haven't heard about ME patients necessarily getting the vaccine and improving, but I imagine that some people are having that experience as well. I would guess that has to do with whatever their long COVID. I would guess that that's an individualized reaction depending upon their variety of long COVID, and I don't know. And I don't know. I'd be curious if that holds up over. I'd be curious to see whether there are really studies really showing that. I mean, that's his own clinical observation, wasn't it?
It's anecdotal for sure.
Yeah.
And it would be interesting.
He mentioned that to me early on, and I saw some reporting about that, and I think that's definitely a phenomenon, and it could be, it's interesting. We sort of think something has to happen to a certain number of people. If it doesn't happen to a certain proportion, it's not a real phenomenon, but these might be mini phenomena that happen on an individualized metabolic basis in some way for some of these things, depending upon their particular infection and their particular, immunology.
One other thing I wanted to get your thoughts on. There was a recent article, I think it was Wall Street Journal, where someone basically said this is all in their heads, and you wrote about this. What exactly?
So
happened?
That was part of the wave of what I sort of think of as long COVID denialism or long COVID skepticism. I think is the word that's sort of being the long COVID skeptics, or I was thinking long COVID truthers. I don't know, but there's been this strain from the very beginning of people who are assuming that these reports are basically psychogenic. That even if they had COVID. First, some of them never had COVID, and they're just imagining it, because of whatever, because of stress and anxiety, and they have a mental health issue. And some of them did have COVID, but now they're just responding to like the PTSD and the exhaustion and lockdown. A lot of people are, responding to lockdown. Of course, lockdown produces mental health concerns and so on. So they're sort of conflating it with that. So this guy, Jeremy Devine, who's a psychiatric resident in Canada, McMaster's University, I think in Toronto, wrote I was kind of repellent actually, opinion piece in the Wall Street Journal about, and he basically attributed, it was called the dubious origins of long COVID. And what he meant was that it was basically created by what he referred to as, a queer feminist wellness collective. And he threw that in there as if that automatically, that they were queer, that it was feminist, and that it was a wellness collective, or that it was about and it was a collective. I'm not sure which ones of those he considered disqualifying, but that automatically, he seemed to have a revulsion against any kind of patients involved in researching their own conditions, because it seemed to be he was offended by the arrogance of patients naming their condition and researching it. And so that was also basically, he criticized the research, like I said, because 2/3 of the people that they surveyed didn't even have a positive test. Well, this is what I just said. Of course they didn't have a positive test, because they did that survey came out, I think, in the summer. It was early, and so people hadn't gotten tests. They just were sick. So he used illegitimate points to invalidate the research, which, again, you can acknowledge that they didn't have PCR tests, but explain why that might have been. And he referenced the PACE trial to show we've already seen this in the past, and this study proved that you could treat these things, without any awareness or concern. I don't know if he had an awareness that, that had been debunked, that trial has been at best controversial, at worst shown to be, research misconduct and or worse, I'd like to say. So and that was kind of then there were these other articles that appeared that I mentioned, the American Spectator. There's been other articles of that ilk. That was probably the worst one. A couple of weeks later, or a week later, they had a counter article, opinion piece by another psychiatrist, a psychiatric resident in New York, who himself has long COVID and was working with the researcher. So he was countering it from the psychiatrist perspective. And it was really a very offensive, and it was hard to see how it got past. I mean, even the Wall Street Journal, it just was really offensive, and just made a lot of unwarranted assertions about it's just mental illness, like these sweeping kinds of things. And the one thing I wanted to point out that relates to Ed Young's most recent article, I guess in September, about long haulers or about long COVID. And so some of the articles have done a very good job of the New York Times magazine had one, Vice had one, where they've said, we've seen this before, this disregard of these range of symptoms, and they cite the ME or ME-CFS example. Ed Young referred to this thing and mentioned the PACE trial and mentioned a now discredited study, the PACE study. And with the now discredited study, and I've been calling PACE discredited or now discredited for a number of times, but more as aspirational. Like I want to throw the idea into the world so that it sort of becomes normative. Like I've said it a little provocatively, but there it was as a normative statement in The Atlantic, and he linked that phrase to our original Virology blog investigation. So it really made me feel good. It's like, oh, I guess that opus, that thing, has some actual existence in the world and is now being cited as evidence of something, even though, it wasn't peer-reviewed, obviously, but that basically, it was just really amazing to see that, but I only saw that in the context of long COVID. Absent long COVID, that wouldn't have been written. Without
long COVID, Ed Young would not have seen it, probably, right? Your article.
I think he'd seen it in the past, but he wasn't reporting about it, so he wasn't reporting on long COVID, and so I think it didn't really have any relevance beyond the ME community, except as a case study for bad science or, the whole thing, but basically it wasn't of interest to anybody outside the ME world. Most people never heard of PACE or knew anything about it. I think it was on Ed's radar a bit, but, I think the long COVID situation made the past criticism, and again, mainly from patients, but of which I was part, relevant in a way that had never been.
I think Ed Young gets long COVID, right? Mm-hmm. So he must get ME-CFS.
I think he gets, it's clear from his writing, and then that he's recognizes that there's a range of these kind of illnesses, dysautonomia or conditions that have really not gotten their due, again, because they're hard to, and that we shouldn't be so quick to attribute what we can't identify or we can't find a specific pathophysiological process at the moment. We shouldn't be so quick to dismiss them as psychosomatic, not to dismiss that the mind has an effect on the body and that depression has an effect, and that not to dismiss any of those things, but it does seem like in this case and in cases that I've looked at, especially when the science is so bad, it's one thing if you want to do it based on good science, but not when you want to do it on some piece of crap like the PACE trial.
Do you think you're going to be on this mission forever, or do you see?
No, I have to at some point. I've been doing this now 6 years, and so now the last few years is, I crowdfunded Berkeley because that's what I do to sustain working on it. I was gonna, I really thought when the NICE guidelines came out, which was supposed to be this year, I could say, okay, they're going to be good, and I felt like I'd done my work, and time to move on to some other project, or, I just turned 65. I don't want to be doing this for the rest of whatever. But, with the long COVID has made it interesting. And it seems that it's made it feel, it's always felt worthwhile, but it's made it feel like urgent in a way that I had, I felt like it always felt urgent, but I felt like I had done a lot of what I could do. And now with long COVID, it seems like there's a bit more that I can do. And, this month or at some point this fall, hopefully, we'll find out what happens with NICE, and I'm sure there'll be consequences from that. So, I mean, I'm thinking I'll do it for another year or so, and then I'll probably think of, another project or something else. I have no idea, really. I had no idea I'd be working on it this long, and it wasn't the way I had, I didn't sit down 10 years ago and say, I've got to be the chronic fatigue syndrome reporter. That's really what I want to do. So this was all sort of a surprise to me that this all came about like this. But it's been fascinating, and, I've met a lot of wonderful people, and I've really, I felt it's been very rewarding and continues to be, so I still do it. I'm crowdfunding now. But, no, I don't see it as a forever thing. And I think I also feel like now there's a lot of attention to this stuff in a way that there wasn't before. And so there are reporters who are handling it normally that before, not the same reporters, but that there's more, I see, especially in the U.S. and in the U.K. as well. I mean, the Times has been really good on the last couple of years reporting on me. And so, I mean, I think there's really been a change, and I don't feel so much like if I were to stop somehow, I at one point I think I had a little bit of savior complex or something, like I couldn't stop, because whatever. But I mean, I see that there's a lot more interest. There's, there's a lot more savvy among groups, I think, of getting, who are, advocating. There's a lot more, people know what ME is even in the US now because of long COVID. So I feel like I've done a good thing, and, I've done it for 6 years, and at some point in the next year or so too, I'll, I don't know. But I have to have something else that grabs my interest.
Well, you will. You'll find something.
So
it's the way it works.
Interested. I'm really interested, actually, in the whole. I mean, this may continue longer. I'm very interested in the whole MUS category, medically unexplained symptoms, and so these are really kind of parts of that. But it also involves irritable bowel syndrome and fibromyalgia and anything that doctors seem to not be able to understand, that they want to shove into this category that they pretend is an actual category rather than just kind of like a grab bag of things that people don't understand. And so that, is, I think, a real problem. And so, maybe, I write about that to some extent, to the extent that it relates to these conditions.
Yeah, well, so you continue to have a lot of readers at Virology blog, I noticed. So David writes frequently at virology.ws, and you may think, why is David on TWiV? But it became, because it started as possibly a viral-induced illness, right, with XMRV retrovirus, and that's how you and I hooked up originally.
Right, that was why. So, I mean, people say, well, why are you writing about this on a virology blog? And, of course, obviously, viruses are implicated. It's very
Clearly.
much
and with long COVID, it's even more clear now, right? So that's fine. But you have lots of people reading. You also write in other venues as well.
Yeah, so basically what I've tried to do is, I've really tried to make it, I'm supposed to be an academic, so basically this is sort of, virology blog is kind of academic-y more than academic, but I also do journalism, so I've written, for various publications, and then also I've tried to do more, and I'm working on a couple of longer academic, journal publications now. As well. So I've been trying to do as well, because there's a difference between having something published in a journal, work that is popular journalism is very, can't really be cited as evidence of anything.
Sure.
And journal articles can be, even if they're opinions. So, I think I've been tried to do some of both, and so I've had a couple of, so that's the way it seems to work best. And for me, it keeps it interesting because I have sort of, blogging I can do, and then more formal journalism articles, and then even more formal journal stuff. And it sort of helps it keep it more interesting for me also.
All right. That's TWiV 816. You can find show notes at microbe.tv/TWiV. David writes, of course, at virology.ws. And if you have questions, you can go there in the comments of his articles. He often responds. Or you could send them to TWiV at microbe.tv. If you like what we do, consider supporting us. Go to microbe.tv/contribute. My guest, David Tuller, University of California, Berkeley. Good to see you again.
Thanks, Vincent. Good to be here.
We tried to do this earlier, but you couldn't come to Columbia.
Right. There was more restrictions. That was in May or June.
Yeah, we couldn't have guests. But here, actually, you are the first guest at the incubator.
Oh, I'm honored.
The first. No one has been here to record a TWiV. I've done them by myself, so congratulations. Hopefully there'll be many more.
Does a prize come with that?
I can send you a mug or a T-shirt. How about that?
Okay. I'll take T-shirts anywhere I can get them.
Okay, I will send you a TWiV medium.
Okay.
All right, I'll send it. I'll get your address later. So thank you so much, and I'm presuming we'll see you next year when you visit again, and we'll have more things to talk about.
Thanks, Vincent.
I'm Vincent Racaniello. You can find me at virology.ws. I'd like to thank the American Society for Virology and the American Society for Microbiology for their support of TWiV, and Ronald Jenkins for the music. You've been listening to This Week in Virology. Thanks for joining us. We'll be back soon. Another TWiV is viral.